Hey, y'all. Quick note before we get started. This one is called How COVID Changed Hospitals, and we recorded it back in June of this year before the Delta variant. So please keep in mind as you listen, because there may be a few times it sounds like we're talking about COVID in the past tense. Even though a lot has changed since then, we still think the information Bill and Vince shared is relevant and can bring some value, and we didn't want you to miss it. Also, this is the last episode of this season. We're currently working on the next, and we'll be back soon with more candid conversations. All right, here's the episode.
One of the things that I think COVID maybe pointed out in the bigger picture is, healthcare is extremely rewarding, but it's not easy. And I'm not sure people always understood that part of it. And I think they do today.
Well, hello, everyone. Welcome to this week's episode of Let's Talk Solutions, Candid Conversations with Healthcare Leaders. I'm Amy Fritzer, Director of Business Development for HHS.
And I'm Becca Leaf, also Director of Business Development for HHS. This week, we discuss how the COVID-19 pandemic has caused the healthcare landscape, both from large and small facilities, to drastically change, and hospitals have had to reevaluate their delivery of care, the patient experiences, and their finances.
And today we're joined by Bill Caldwell, who's Market CEO for Conemaugh Health, a system in Johnstown, Pennsylvania. And then also Vince Sica, who is CEO of DeSoto Memorial Hospital, located in Arcadia, Florida. Both have a combined over 30 years experience in managing hospitals and systems, and so glad they're here today.
Welcome, Bill and Vince. We appreciate you taking the time for joining us today. Let's go ahead and get started.
We purposely wanted to choose to bring in two guests for this episode of the podcast to get a different perspective from both a larger facility system and a smaller one. And, obviously, as previously mentioned, you both have extensive experience in healthcare. So would you mind both kind of introducing yourself and give us a little background into your healthcare experience?
Sure, I'll start. Once again, Bill Caldwell with Conemaugh Memorial Medical Center, Conemaugh Health System in Johnstown, Pennsylvania. Extensive background from the not-for-profit to the for-profit side, large hospitals in urban areas to smaller hospitals in what I would call semi-rural. And Johnstown's a great example, the city of Johnstown. And our primary service area is about 120,000. The city's about 25,000. So it's a little bit more than just strictly a rural area, but it becomes rural very quickly once you get outside of the city of Johnstown. So we're located about halfway between Harrisburg, Pennsylvania, which is the state capital, and Pittsburgh. We're the only level 1 trauma center in that geography, regional neonatal. I've been here about almost 3 years now. So, and a lot of healthcare experience, I will tell you, no experience with the pandemic previously.
Well, good morning. I'm Vince Sica. I've been the CEO here at DeSoto Memorial Hospital since September of 2006. We've seen a lot of changes. We're a small rural hospital. We're a 49-bed sole community provider designated hospital. We're too close to some other hospitals on the coast to get the designation as a critical access hospital. So we're 49 beds. It's interesting. We're in a small community. There's about 35,000 people in the county, about 8,000 people in the city of Arcadia. During the winter, we have a real population of winter visitors that come, and the population is probably closer to 60,000.
Wow.
We have several RV parks and people that come and stay the winter with us. Typically, we have a lot of Canadian visitors, but we obviously didn't because of the pandemic. And, I'm with Bill in that, I've not had experience with the pandemic other than I remember as a child getting my polio vaccine in a sugar cube at the local elementary school.
Yeah. My mom was telling me that exact same thing. You line up, have your hands out, and take the sugar cube.
And I'm sure there was no record keeping.
Yeah, exactly.
Not like there is today, that's for sure.
Bill, did you have to do that too?
Oh, yeah. I'm of that age where, I can remember all the vaccines and the sugar cube. Actually, I hate needles, so the sugar cube was a great option.
Yeah. Especially for kids. I'm smart.
Yeah.
So the first question I really have for y'all, last year the safety protocols took a very dramatic shift in terms of COVID. Are there some protocols that you have relaxed versus some that you think will really stick around forever as a change?
I believe so. We're still screening everyone that's coming into the hospital. With the ask them the few questions and taking their temperatures. And we've not opened our main entrance yet, and we're in the process of getting ready to do that. As a small community, our cafeteria was, a lot of people came to the hospital just to have lunch.
Right.
And during the pandemic, we closed the cafeteria for the outsiders,
Right.
and then we've loosened it up a little bit so that if you're in the hospital getting some sort of procedure or you're visiting someone in the hospital, you can go by the cafeteria. But with regards to the utilization of PPEs and I think that's with us to stay. I think some of those are good practices that it's just a matter of time before we implemented them. And of course, now the issue is, do we have enough of them? And I think they're moving in that direction. I know the style of the N95 mask has changed, and there's a couple of different options. And so as we move forward, I think that that there's some good that's come out of it in terms of just professional practice.
So with the PPEs, Vince, when you say you think that's here to stay, do you just mean for staff or for visitors and patients too?
Staff.
Okay.
I think staff, especially when they're treating, the staff in the patient care areas will probably continue to wear their N95 masks whenever they're in a treating a patient.
And do y'all have visitors wearing masks still, or has that been
We
lifted?
do. We ask everybody that comes to the hospital to wear a mask.
Gotcha. What about y'all, Bill?
Yeah, pretty much. I mean, we've loosened up a little bit. We're not screening right now. It's on the honor system. We've got the devices that can read temperatures. So as staff or visitors walk through, it's being recorded. That's worked pretty well. We still have all the restrictions around masking within the hospital patient care areas, mm-hmm. and also in common areas like the cafeteria. So I think some of those things will stay in place, at least while from the regulatory side, at least within Pennsylvania, we're required to do so. But I do think there are some things, that are lessons learned. And, there's a reason we didn't have much of a flu season this year.
Right.
And I think a lot of that goes back to just masking and, reinforcing hand hygiene and social distancing. And, while a lot of people struggle with those things outside of the hospital, I think they do have a place on an ongoing basis within.
Mm-hmm. Quick question is to follow up. So when we were kind of going through our previous conversations about this, you both had mentioned, and again, I'll just go back to Vince about how the protocols and stuff affected your facilities, separately. Obviously, there are very different regions and different states and different sizes. And Vince, you had mentioned about being a smaller facility that you treated everybody as having COVID because your main concern was not only, of course, the patients, but your staff, right? And
that's correct.
Staff members have to quarantine and things of that nature. And with you being a smaller facility, if you had a significant portion of your staff be out for an extended period of time, that would, really affect, the care there, right?
Absolutely correct. And that was our biggest concern. And, one of my pet peeves is that, and I'm sure Bill can say the same thing, is that, we want to protect our staff the best that we can possibly can. And, we encourage them to do what's right for them and their coworkers as well. So it's just sort of going hand in hand. But, even, normally, with regards to just basic security, it's, we always want to protect our staff to the best we can from any type of adverse event.
Mm-hmm.
Did y'all do that from the get-go, Vince, or did you start to see, some people getting out sick and have like a reaction to it?
We started it from the very beginning. We recognized that our staff was, vulnerable. So we utilized as many PPEs as we possibly could. We got pretty creative in terms of with when gowns become in short order, we started buying. We found a source of ponchos that were that we used from I believe Amazon, and so we started using those as well to help supplement with our gown shortage. But and then we did ask the people to wear their N95s more than just a day. We kind of double masked with the N95 and then with a sort of throwaway paper mask over the top of that for a long time.
And Bill, did you see anything like that too? Staff that had to be quarantined or be out, or how did you combat that?
We did. I mean, I think what was interesting is we did a lot of contact tracing and symptoms and all those things. Most of the contacts were outside of work. And there were a lot of challenges around how people would, I don't want to say behave, but I guess, how they followed the appropriate protocols outside in terms of when they mask, where they, socialize, that type of thing. But the quarantine was a significant challenge for us during the peak of COVID. We were placed in the situation of having to pull in, say, registered nurses from non-bedside functions to help on the floors, case management and clinical informatics and places like that. At the height of COVID, which our primary surge was in probably late November through December into early January, we'd have 120 to 130 people out at Conemaugh Memorial on any given day.
Wow.
And some of those were truly positive, but some of them were just through contact tracing. We had to hold them out.
Yeah, preventative. Yeah.
Was somebody dedicated? Do you have an employee dedicated to contact tracing? Was that their sole role?
We did it through our employee health department.
Okay.
We've got on this campus, over 2,300 employees. So, we've got a couple full-time RNs in employee health and a part-time physician, and they did most of the contact tracing to the extent they could.
Right.
We did the same thing. We did the contact tracing through our employee health nurse. We had, and as with Bill, some of our worst situations where we had to quarantine people was, people that got together outside of the hospital.
With each other or with other friends and family?
Both, with each other and then bringing in some sort of outside source. I think kid birthday parties in June and July were, a problem sometimes.
Yeah. That's tough. I feel like that one, your employee in relations to the person that's tracking it has to really be up on all the gossip almost, who's friends with who hung out with who.
That's very true.
Some of it became pretty self-evident just based on who was calling in ill.
Yeah.
Oh.
Yeah. Exactly.
I never thought of that. So you guys, obviously very different communities. And Vince, did you have a peak season there at DeSoto Memorial, or did you just kind of see it constant and consistent throughout?
Well, I had to laugh because in June, July, and August we were really one of the higher percentage of positivity rates, and they would show the map of Florida, and there did be this little red square that no one ever heard of before, and that was DeSoto County. And
wow.
So it wasn't anything we were proud of. And then, as Bill said, right around Thanksgiving, Thanksgiving, December, we had some real issues where we got concerned about the number of people that were positive and the number of people we had in the hospital. We have some correctional facilities in the area, and they had quite an outbreak within their facility that, sent quite a few patients our way. And, those are pretty large facilities. I think the state is like 1,200 inmates, and the other civil commitment center has right around 600 residents as well.
Wow. That was interesting to me because I think you see a surge obviously in the regular population that you normally serve because of COVID cases, but then you have these other populations that maybe don't necessarily seek medical help that you're now having to serve as well because of this pandemic.
Well, and those people probably, are exposed to the guards.
Right.
So
Yeah.
clearly they had people going, from outside coming in and to expose those people because they don't go anywhere, obviously. But
Yeah.
it was a concern.
Bill, did you see anything like that within your community?
Pretty similar.
Did-
I mean, anywhere there's congregate type of housing, whether it's in a prison, in a long-term care facility,
Mhm.
the ability to social distance and do all those things obviously becomes very limited. And, they're just ripe for that type of spread. We
Yeah.
saw the same thing here. Prisons, nursing homes, the assisted living facilities were all areas that we saw patients coming from, in addition to just the community as a whole. And I do think, that post-Thanksgiving, I think, quite frankly, a lot of it had to do with Thanksgiving.
Yeah.
Yeah.
I mean, we've been into COVID for a while, and I think people were looking for a little bit of a break. And, while we talked about the need to social distance and be thoughtful about how we celebrated the holidays, I think it was a little bit problematic, and that led to, fairly pronounced surge.
Mm-hmm. Bill, this might be a super ignorant question, but are you close to Amish country at all?
We are. In fact, we've got a fairly significant Amish population.
Did they seek help during COVID?
They do. They use healthcare. In fact, one of our critical access hospitals, its Facebook page and website has a car and an Amish buggy as kind of its.
Oh, that's cool.
That's what they're identified with. Interestingly, we didn't see that many COVID patients from the Amish community. I think that may speak to somewhat a little bit more isolated.
Yeah.
Very careful.
Mhm.
I've read a few things where there's actually, they believe, some now herd immunity within the Amish community.
Interesting.
So that was not an area that we saw differences in terms of presentation.
Gotcha. Well, the other theme too that we wanted to talk through about potentially changing because of COVID is the idea around telehealth.
Mhm.
So obviously anyone that was not experiencing COVID symptoms but had other medical issues,
Mhm.
we resorted to telehealth a lot of the time during the pandemic. It seemed like there was an overload. Did you face a lower census, first of all? I guess that's my first question, on non-COVID cases.
We did. I mean, we saw people staying away from the hospital for, certainly elective types of procedures, postponing routine mammograms, colonoscopies, the emergency department, the lower level ED visits.
Mhm.
We saw a precipitous drop.
Was that patient driven, or do you think it was, driven in terms of, the facility itself?
It was entirely patient driven. I mean, I think people being fearful of coming into the hospital environment. Uh, people just fearful of leaving their homes in general,
Right.
much
Yeah.
less come to the hospital. So that was very real. I mean, I think the telehealth, helped mitigate some of that. Here at Conemaugh Memorial, we've got several pretty robust telehealth programs, specifically around neurology and stroke care with
Mhm.
some of the outlying facilities. So we had a fair amount of experience with it, but we were able to extend it into our primary care offices. And a lot of people really liked the notion of seeing their physician. And quite frankly, it was more convenient for them. You don't
Yeah.
have to get in a car and come into the office.
Oh, for
Now,
sure.
I think the flip side is there are certain things, and this is what I've heard from the physicians, that clearly you do need to be seen in the office and how you balance the two. I think the other thing that the telehealth pointed out is maybe a longer term infrastructure issue. And this is certainly true for a lot of rural areas, is just access to, broadband and high-speed internet.
Right.
Yeah.
Yeah.
A lot of rural places don't have it. So
Right.
Yeah.
the ability to make a telehealth visit work in those environments is challenging.
Right.
Yeah. It's like, do you hop on a computer or do you go to the office?
Well, for some of the docs, it was great because they didn't have to go into the office. They could do it from home,
Hmm.
and it worked well.
We saw the same thing. I've gone on record as saying COVID-19 was the greatest ER diversion program we've ever had. Our ER volume for the what I'll call non-emergent things really dropped significantly during the pandemic.
That makes sense.
We've always known that telemedicine was a good vehicle, and as we've moved through this, the question was that none of the payers really wanted to pay for telemedicine, and especially in the rural communities to get specialty consults to your patients. It really works well, and we also have the telestroke and teleneurology programs, and that's huge when we've got quite a few stroke protocols that we can get them into the CT almost immediately and
Right.
as quick as we can, and get that information to the neurologist. And we have the telemedicine cart, as we call it, so that the neurologist in Sarasota can examine the patient, and based on that, and then what he sees on the CT, we can, if we have to airlift them to the big hospital, we can.
Mm.
And then, and obviously if we need to give them one of the clot busters, we can do that too. We can do TPA here as well.
Mm.
So that's really a good thing. And then, we've utilized a couple of the telemedicine for the primary care.
Mm-hmm.
We also we have a couple of physicians in the community that are proponents of the direct primary care, which is sort of the concierge type facility where you pay a membership fee.
Gotcha.
And you don't pay anything through when you go to the physician.
Mm-hmm.
And they even utilize the telemedicine. And, I think patients like it because they, a lot of times in the past, when you were sick and you'd call the doctor's office, they'd say, well, we can see you in 3 days.
Yes.
So,
right.
That's not the answer a patient wants to hear. And so, being able to say, well, I can have the doctor call you via, some type of video call in an hour or so is a much better outcome. And, and obviously a lot of it can be done by, some of the things. And obviously the doctors know when they need to see the patient.
Right.
Mm-hmm.
Right. They're trained on when to do that.
Yeah.
So they can at least make that judgment call immediately.
Is telehealth cheaper to the patient, or is it the same cost?
Telehealth is, I think the payers are paying a fee. I'm not exactly sure what it is, but I think Medicare is treating it just like a regular office visit.
Okay.
And that does vary somewhat by payer. I mean, I think from a patient's perspective, there's a convenience factor and there's a reduced cost at some level. Forget what they're paying the practice, but just the travel time and gas cost and things like that.
Mm-hmm.
It does save the patient on that side of things.
Or if they have to pay someone to transport them, maybe they don't.
And that's very real for a lot of patients.
It is, right.
So what percentage do you guys think are, regular inpatient visits versus telemedicine? Is it pretty even, or?
I would, telemedicine is still fairly low, but I do think I think that will increase over time. Vince's point earlier on telehealth, a specialty consult, in a more rural setting that may not have that specialist on site.
Yeah.
It's a great way to improve access. And I think that's where you'll see it adopted. There are still some regulatory, and this varies from state to state, regulatory hurdles that will need to take place in addition to the reimbursement side. But that's, I think, one thing that is clearly here to stay.
Do you anticipate that increasing or staying the same as it is now?
It's going to increase.
You think, well, yeah. Like what percentage would you guess?
Boy, that's a hard question.
I know. It's
I'm
pretty
not
hard.
sure, you know, I think a lot will depend on, quite frankly, where you are.
Yeah.
Some states have really pushed telehealth. I worked previously in North Carolina, and they've done a great job in Eastern North Carolina of through grants pushing behavioral health uh, into primary care offices and emergency departments that did not have a psychiatrist on staff. And in those scenarios, the utilization was significant.
Mm-hmm.
The hospital I was at, every behavioral health patient that came into that ED was getting a telehealth consult.
Right.
And that would be, that could be, hundreds of patients in a month.
Wow. Right. Well, you brought up the mental health piece of it. That was something I wanted to talk to through recruiting, and just shifting gears here back to your staff. I know you had mentioned when we talked before, Bill, that there's this PTSD, frankly, of your employees, and you think that that's going to be more prevalent in the coming months. Do you want to maybe elaborate on that a little more?
Yeah, I think resiliency for all of us coming out of COVID or during COVID, we all felt it at some level, the things that we like to do outside of work that we couldn't do. Right. Something as simple as going to dinner. So if you got that toll that it took on all of us, add to that the stresses of being a caregiver, through the pandemic and having to deal with the challenges, the number of patients dying and, the isolation that these patients felt because they couldn't have family members or visitors. That takes an emotional toll on the staff. And I think we're going to see it manifest itself in a number of ways. One of them is the true PTSD. And I don't think we'll see that, maybe for several months, 6, 12 months, just like, somebody who's been deployed in a combat zone. You don't see PTSD from day one when they get home. There's that delayed impact.
Right, exactly.
But I think resiliency is a huge issue. The most important thing is, recognizing that it's out there. And unfortunately, in healthcare, we have a tendency to just say, power through it. I can manage this, when no, you may not be able to. Being able to provide resources for our team so that they can seek help, and that it's okay to seek help.
Mm-hmm. Yeah, and when it comes to recruiting, Becca and I, we talk to administrators and stuff all the time, all over the country. And one of the main concerns is recruiting staff, right? Whether it's your hourly within the facility, on the support services side, or it's the clinical side, or especially nurses. And, have you guys seen, obviously kind of following what we were saying, Bill, the PTSD factor coming into play, which I agree with you, I think is extremely real, and probably will start manifesting itself in the coming months, if not years. But so Vince, you being, in the smaller, more rural community, how did you and your facility battle that? Did you see several nurses maybe, not choosing to come back? Or if you needed additional staff, how did you guys combat that?
Well, one of the things is it's very real. I think that, if you go into a healthcare profession, you're a caring person, and you hear the stories of the couple that were married for 50, 55, 60 years, and the wife is looking at the glass at their spouse for the last time, and those are powerful messages that I agree with Bill that we've got to provide some sort of behavioral health for our staff, and we try to do that through our employee health. We have options. We have a bit of a behavioral health program here as well. So they have access to those resources with our clinical social workers, as well as the psychiatrist. And so those are available. But, as we move forward, I think that, we saw a lot of changeover in that. We lost quite a few nurses to, the travel assignments, where there was some really enticing revenue streams to get, because nurses were really a hot commodity, and just like anything else this day and age. And so, we had to backfill with, we had to hire some people and give, some what I would call crisis pay to some of our really good employees to keep them here.
Right.
So it was an interesting time, but our thought is, we need to provide, whatever resources we can to ensure that our employees have the, access to the resources they need.
Mm-hmm. Do you think that might be, kind of retaining the healthcare staff, or, whether it be nurses or whatnot? Do you think that's going to be a challenge kind of even in the next year or so?
I think so. I think that right now there are some opportunities there because, there was a nursing shortage. I think there might be now more people interested in going into nursing. I know I just actually read something that this morning that the University of South Florida is expanding their nursing school, or their class for the nursing school, which is a good thing.
Yeah.
And but I think this might have precipitated, because I think right now, healthcare workers, there's a good feeling about the service they provided
Right.
during the pandemic. And so I think it might have reinvigorated people going into that line of, as a career.
Yeah. They want to be a part of something to make a difference,
Yeah.
Yeah, I would concur with Vince. We've got a number of, we've got a hospital-based school of nursing here, as well as several 4-year programs. And the interest in the nursing profession has certainly increased. I think part of the challenge is, though, on the flip side is you've got some folks retiring early. You've got some folks moving away from bedside nursing to other types of nursing careers that maybe don't have some of the challenges of working in a 24/7, 365.
Like administrative or things like that.
Administrative, going to work for an insurance company, or the operating room nurse that moves from the hospital to a freestanding ambulatory surgery center where it's Monday through Friday, daylight hours
Right.
only. I think the one of the things coming out of COVID is I think it has amplified some of the lifestyle choices that everybody makes. But, I think it's more prevalent in those sectors of our economy, and healthcare being front and center, that, aren't a Monday through Friday, 9 to 5 type of job.
Right.
And we've seen it here in Johnstown with some of the manufacturing concerns, that run second and third shifts. They're struggling with the same thing from a recruitment perspective.
Yeah, I agree. I mean, I've seen it. I mean, we see it all over the country. It seems like recruiting in any industry is really tough right now.
Yeah. And Vince, when you said more people are doing like that South Florida school had a higher nursing class this year, I wonder if it's too because so many people got laid off this last year, and nursing is a job that it's like, wow, that's always needed, and people are kind of shifting.
That's probably true. I think that the need for good health care was never more evident than the last 16, 18 months. And so I think it's reinvigorated people wanting to take a career in healthcare, because they realized that we didn't really suffer any of the layoffs or whatnot that other previously careers had provided. I know a lot of people ended up working from home for a long time, and then eventually were laid off. And it's tragic when you're the breadwinner of a family and have some circumstances way beyond your control cause you to lose your livelihood.
Right. Exactly. Yeah. Do you think it'll stay like that in the healthcare realm, where people will continue to try and switch?
I think for a while. I think it's cyclical, and then we'll see something else come in. But I think some of our nurses are going towards a lot of our good nurses are going to the advanced nurse practitioner, the APRNs, and then also into the other, as Bill said, either case management, which is We have a lot of nurses go into case management. A lot of nurses go into the, a nurse that has really good computer skills is invaluable in this, in an MIS department when, the electronic medical records and building all those interfaces and whatnot are, that's what we do day in and day out now. And, those are just invaluable to have, because you don't want a computer person building something for a nurse because it doesn't work.
Yeah.
And you don't want to have a computer person building something for a doctor. You need a doctor building something, that knows some computers to build it for you.
Yeah.
Otherwise, no one's happy.
Right. Right. I was wondering about that when you were talking about telehealth. I was thinking, how much of a learning curve was there for some physicians having to utilize those programs?
Yeah, I think on some of those things, physicians have become more and more tech savvy, as we all have. The ability to use, their smartphone as a means of communication. And, I think to Vince's point, though, there are a lot of complexities in healthcare that you really need to have clinicians as part of that planning and implementation process. And, information technology is a huge one. Is if you don't do it the right way, all the things that you would hope to gain from an EMR, you're going to lose.
Right.
All the different layers, all the different steps, all that has to be mapped out. And like Vince, you had mentioned, IT doesn't know healthcare and vice versa. So you need to make sure that the healthcare professionals kind of driving the bus on that, I would imagine.
Yeah, just to make sure it flows properly. It's just because they can draw it on a piece of paper and say this ought to work. Let's make sure it works in practice. And but it's it's a never-ending thing. And every time you need to connect one system to another system, you have to purchase what they call an interface from your main EMR system to whatever you want to add on to that, and that creates problems with security as well as basically the expense. And obviously some of the hospitals have been hacked and had with the ransomware and everything.
Right.
That's a big concern, and I know our MIS department is always sending out different reminders about don't open this, don't do that, and make sure we maintain all the security that we have in place.
Right. Did you guys see, even in like your cafeterias and stuff, moving to more technology and less paper, less area, like touch zones, where you'd have like QR codes for menus or things like that in your facilities at all during COVID?
Oh, absolutely. Just even something as simple as how we check out in the cafeteria, it's scan your own item, little things like that.
And you think that's here to stay, right?
Oh, absolutely.
That's such a convenience too. That's the thing, you try to look at the silver lining in things, and maybe that's one of them is things are always change and evolve, but it seems like COVID's really kind of pushed it to go probably in some areas quicker than was expected or thought to happen.
Yeah, actually one of our biggest dissatisfiers right now is when we closed we had a great salad bar, and we've still not, I don't know if salad bars are ever going to come back.
Yeah.
And unless you have an attendant there that's going to, with gloves on, is going to portion stuff out for you. But we're still working on what we're going to do with regards to our salad bar.
Yeah.
Yep, we brought it back with an attendant.
Did you? Yeah, like that.
It was too much demand. Really
I would be there every day.
One of the little things that we did that was a huge staff satisfier is, as during the pandemic, it was hard sometimes for people to get to a grocery store or whatever. So our food services department started doing things like get your milk, your loaf of bread, some of the basic staples that when people would come through the cafeteria, they could pick up that loaf of bread, that jug of milk to take home. Huge satisfier. And that's something we're probably going to keep. Just, the convenience factor.
Exactly.
That would certainly help if they're there and then can't, like you said, get to the grocery store. It's like, oh, wait, I'll just run down to the cafeteria, get some milk. Do you guys have coffee creamer too? Grab and
Yeah,
go meals.
yep. Yeah, we do grab and goes.
That's smart.
Yep.
So just switching gears here a little bit. So we all know about how COVID has affected supply chain models, right? And service models. I mean, in terms of, Vince, I think you mentioned it earlier about the PPE aspect. So have you guys had to kind of reevaluate your supply chain models in terms of, getting supplies and things of that nature? Or how did you adjust to that last year? And are you still seeing, after effects of that now?
Well, we worked with our supplier. A lot of times what happens is you get built into, like if you're ordering, 4 dozen of this on a regular basis, then they sort of limited you to the 4 dozen. And during the pandemic, we probably needed 8 dozen. So, you had to manipulate the staffing or supply chain model. And then we would look for other resources. I mean, we bought quite a bit of stuff on Amazon just to kind of make ends meet. And then fortunately, we ended up getting quite a few cases, I should say, of face shields from Ford Motor Company. And then the Harbor Freight delivered a bunch of gloves and face masks or shields from their resources. So, that was pleasantly. And our CFO graduated from Notre Dame, and I guess Notre Dame had some sort of resource where they were making face shields. So we even got some face shields from Notre Dame that included these little wooden coins that were pieces of old bleacher seats from the stadium.
Oh, that's really cool.
Did they have the Notre Dame emblem? Because let's face it,
They did.
Yeah, of course. Of course.
Marketing.
Hey, I'm a Notre Dame grad, so.
Are you?
Oh, are you, Bill?
There you go.
But did you get some face shields too?
No, we did not. We were really lucky with supply chain. We did get a fair number from Ford Motor Company, and many thank yous and kudos to Ford for doing that. We had to conserve a lot on the supply chain, and some of that conservation was really just around the uncertainty, in terms of, how that was going to look, week, 2 weeks, 3 weeks down the road. We did regular forecast as a company to say where we might have supply chain issues. To me, that's one of the things, though, that I think COVID maybe pointed out in the bigger picture is the fragility of some of our supply chain, for, quite frankly, some things that are pretty basic,
Right.
Mask, PPE gowns, things like that.
Gloves.
And I think that's going to be something that, as we get back to normal, at a larger national level, really needs to be evaluated. And how can we, prevent that from being an issue in the future?
Yeah.
I know we received from the Federal Depository probably mid-March, we received 1 box of N95 masks that had expired in 2007. Wow. And that was all we received from the Federal Depository. So I agree with Bill that they probably really need to look at creating a better system for in the future. And then obviously you always got to deal, we deal with it every summer when there's the hurricanes, is that, the profiteers come out of the woodwork. And, there really needs to be probably some sort of federal mandates with regards to that, because it gets ridiculous. Yeah. I know, we were getting emails from people wanting to sell, a mask for, $5 a mask.
Yeah.
Like that, which is just terrible.
Because how much are they normally for you?
Before the pandemic, they were like 50 cents a piece.
For your GPO, it was like that.
Yeah.
Yeah. Wow. That's insane.
Yeah, Vince, I'm in Houston, so I'm in the hurricane zone too, and I know exactly what you're talking about. When, it seems like, to your point, that this may make things look at not only redoing the supply chain model, but thinking ahead and maybe stockpiling some items even for the future, whether it be on the federal level or the state level or, the hospital level. I don't even know if that's doable, but just, thinking out loud on things to be maybe prepared. I mean, I know like here in Houston, we always get ready for hurricane season. We make sure we have bottled water and we have plenty of batteries and we, this and that. So I'm not saying hospitals don't already do that. I know y'all do, but I'm thinking on a grander scheme, like you said, you got one box of N95s that expired 15 years ago. What are you going to do with that? That doesn't help.
Well, I think, we see that. I think it varies from state to state. We were fortunate in Pennsylvania that the Pennsylvania Emergency Management Association had done some of that stockpiling, and we were able to tap into it if we needed to. We were fortunate. We really didn't need to, but some other providers did. And just being thoughtful about how we prepare for emergency management situations.
Mm-hmm.
I think sometimes that's where folks that live in the hurricane zones maybe have an advantage. You have to think through some of those things a little bit more.
Mm-hmm.
And but I do think there's that larger piece that just goes back to part of the thing with the pandemic. Unlike a hurricane, you have the issue. It may be with you for a month, maybe, whereas the pandemic was ongoing.
Right.
It was
right.
And that's what was very different. I've never had a disaster, situation where the command center was stood up more than a couple weeks. And
Right.
here it's, it's been stood up for over a year.
Yeah. Yeah. I feel like, there's lots of like heartfelt stories and then stories about supplies, things like that were covered by the media during this last year. But is there anything, I'm just curious from a personal standpoint, was there anything that was, highlighted in the media that you were, or not highlighted in the media that you were surprised about, being someone that actually lived through it?
Well, early on, I think the development of the testing devices was miraculous. Early on, when we have basically had the state testing facility, and it would take, you would have someone would come in with symptoms, you'd swab them and send the sample or the specimen off to. We sent ours to Tampa, and it would be days, sometimes a whole week, where this guy's quarantined, he's quarantined for a week, comes back negative. Well, and by, let's say, last probably, I know that maybe by October, like Sarasota Memorial, which is one of our big tertiary hospitals close by, they had a device that, we were getting our results back in, 24 hours or less. And then by November, we had our own test, the Abbott devices that, we were able to, do the PCR test, which is at the time the gold standard within, we were getting results back in less than an hour. So that kind of, true implementation of how everybody worked together to get those things moving so quickly was really miraculous. Just like the vaccines. I mean, typically the vaccine takes years to develop, and now to get that and get those many people vaccinated in such a short period of time. A lot of people. The coordination between a lot of different factions was just incredible. I think that there's a lot of people that deserve a lot of credit for getting the end result to the people.
Yeah, I would agree. I mean, I think when you take that big step back, those were just incredible things that, from just a pure clinical technology perspective. The one thing that I loved within the media, this I guess varied a little bit, but just the how the folks that work in healthcare were being viewed in a positive light. I mean, healthcare is extremely rewarding. but it's not easy. And I'm not sure people always understood that part of it. And I think they do today.
Yeah.
Agreed.
Well, one thing we like to always end on is a fun question. So in this question, this one's pretty silly. And if you can't find this one or figure this one out, we have a second question too. But the first question we have is, do you have a favorite dad joke or a joke that you say all the time that maybe your kids or your nieces or nephews or grandkids are like, okay.
Favorite dad joke? That's a tough one.
And if you want to call a friend, I can give you a second one.
The one I liked this recently was something about, a seagull flies over the ocean and, but if he flew over the bay, he'd be a bagel.
That's a good one.
Yeah. I like that.
I like that one too. The other question.
I was going to say, what's the second question?
Okay. Yeah. Feels like no way. Okay. If you had to teach a class on one thing, what would you teach?
Oh, wow.
We stumped him again, Becca.
No, it's funny. I love to teach because I years ago coached travel soccer, and
cool.
That was every practice was teaching. I think in terms of within the healthcare setting, I think I'd probably be going back to something along positivity and although it's very complex and complicated, the importance of resilience and enjoying life and carving out time for family and what's really important. So something along that line of how to manage your time so that you can get work done, but also get the things that are important outside of work done and completed.
Yeah, I love that. And I love to hear that from leaders too, because I think it is such a cultural thing within corporate America, and it's got to be driven from the top.
Well, and leaders need to do it better.
Yeah.
I mean, that's so.
Exactly.
Work-life balance.
Huge.
It's very true.
Yeah, it is.
And hopefully that's something that sticks around post-COVID.
Yeah. Well, thank you guys. We so appreciate you joining us today and for your insight and the humor and the realism and understand, it was just really interesting learning the different perspectives from the different communities and your different facilities. So thank you so much for being here.
You're quite welcome. Thank you.
Thank you, and have a great day.
I really appreciated how candid they were on a lot of topics, especially the media one. I mean, that was just a random question that popped in my mind, and I had always been curious about that, right? Because people that are reporting it aren't actually living it all the time. And so I really loved what they had to say about that.
Yeah. And I loved how they talked about, the healthcare workers getting their due. And because we all know it's hard, and empathy plays a big role, and it's a special person that goes through that. But they also are going to feel the effects, mentally, like we talked about in the very beginning. And it was just interesting. I just love learning about it, especially from, like you said, leaders, right? I mean, they lived it every day. It was their job to make sure, they're CEOs, so they had to make sure that their staff was safe, and they had, their facilities had everything they needed, and to try to make adjustments as they could. And
yes,
I thought it was really cool.
I did too. Well, thanks y'all for joining us for this candid conversation about the impact of COVID on hospitals.
Yeah. And, thanks again, Vince and Bill, for joining us. And thank you for listening. We hope you've learned some insight today like we did.
Be sure to follow us and tune in for our next episode with another healthcare leader, wherever you listen to your podcasts. And for more tips in healthcare, follow the HHS blog at www.hhs1.com. Until next time.